there now? Probably I will start on time. So good afternoon and evening, everyone. I'm Professor Chair of the ISN OSEA, and it's a truly pleasure to welcome you to today's ISN OSEA Clinical Case Pathological webinar. Thank you for joining us from across OSEA region, even if it meant skipping lunch, dinner, or both. This session are more than just clinical exercise. The opportunity to sharpen our diagnosis thinking, exchange regional perspectives, and learn from real-world cases that reflect the complex reality we all face. And with any luck, we will walk away to a few aha moments too. You may have seen the teaser we circulated earlier, a preview of today's case, provocative title, Ticking Time Bomb, Caught in Time or Left to Explode. It's feature of 50 years old gentleman with known systemic sclerosis who present with progressive dyspnea, edema, hyponatremia, dark urine, and worsening kidney function just a week after head trauma. The case will be presented by an excellent team from Hospital Raja Permaisuri, Bainan, Ipoh, Malaysia, Dr. Quarrel, Lyman bin Ahmad, Shanisa, Dr. Anusha, Khalil Yana Sundaram, and Dr. Tong Khao Min. We in for a thoughtful and engaging discussion, and thank you Sunita and Alex for coordination. Please feel free to jump in, type your question in the chat or raise your virtual hand. If you're speaking, kindly unmute yourself and let us know your name where you're joining from. It's always nice to put a voice to a country. So, Alex, are you ready? Do you want to say something before we introduce Dr. Coral?
It's hi everyone. Welcome to this CPC conference. It's an honor to be part of the team. And yeah, we have an excellent lineup today. And I will pass the time to Dr. Khairil. Dr. Khairil is one of our fellows in Malaysia. And he will be kicking start and will be presenting about the case. We'll pass the time to you.
Your background view is very gorgeous, Alex. Okay. Dr. Khairil, are you ready?
I'm ready. I'll share my slide first.
So the teaser is I pushed into the
right. Can everyone see my slide? Okay. So I'll start first. My name is hi. Assalamualaikum and a very good afternoon to everyone. My name is Khairil Ilman. I'm a nephrology fellow from Hospital Raja Permaisuri Bainan Ipoh. Together with me, Dr. Anusha, our renal hepatologist, and also my consultant nephrologist, Dr. Tong Khao Min. And we are actually from hospital in Ipoh. For those who not sure where is Ipoh, Ipoh situated around 1.5 hour journey from Kuala Lumpur. And this is our hospital. It's a very old hospital, around 45 years old building. It's a very nice place to be in. If anybody haven't come to Ipoh yet, please do visit us in Ipoh. We are one of the best places to visit based on one of the paper posted recently because we have a great food here. So please do visit us here in Ipoh. So back to our case, a bit of an introduction from before we start our discussion. Okay, so I would like to introduce our patient, Mr. SC. He is a 50-year-old Chinese gentleman working as an aircon technician, married with 3 children. Recently was diagnosed, not recently, it's almost less than a year ago, was diagnosed with systemic sclerosis from our private hospital here in Ipoh. At that point in time, he presented with Raynaud's phenomenon, arthritis, and some skin tightening. So he was actually treated for diffuse cutaneous systemic sclerosis since that time. These are all the presentation. He had skin tightness, Raynaud phenomenon, polyarthritis, gastroesophageal reflux disease, got sclerorectally with digital ulcers, some bit of calcinosis, and also the autoimmune profile, the ANA, and also the anti-SCL70 was positive. These are all the medication that he was on prior to see us. As you can see that he's on low-dose steroid, on MMF, pantoprazole, cardiopin, and antihypertensive amlodipine, and also hydroxychloroquine, already been started from our private rheumatologist. At the first time he actually presented to us was in May this year. He actually presented with 2 weeks history of progressive shortness of breath associated with edema, reduced oral intake, and notice having dark colored urine. And a significant history 2 weeks prior to that, he actually visited a private hospital because he sustained a fall. It was quite a traumatic fall because he had a small extradural bleed, multiple facial bone fractures, which actually at that point of time they were treated conservatively. On initial examination, noted that the BP was high, 160/90. He was afebrile. Noted there is edema and scrotal swelling. There is a lungs, there is a capitation more on the right lower zone. There is evidence of hematoma, bruises, and some conjunctival hemorrhage, and also features of scleroderma, like we mentioned it previously. So these are the initial blood investigation. Noted that the platelet was a bit on the lower side with the high white cell count. His creatinine was 126 micromole per liter, and noted 2 weeks prior to this, her creatinine was actually normal, 59, double up in the past 2 weeks. Liver function test noted that the albumin was low with high EST, and urine and family, there is some evidence of hemoproteinuria.
I just wonder, is there anyone who can comment about the differential diagnosis at this point of time, and what would you order next? Is there any speaker that would like to join us for the discussion?
I think we have so many fellow here. So anyone want to
Can we get
hear first?
from
I'm Purapon, the first year fellowship at Chulalongkorn Hospital. I would like to discuss this case. I would like to summarize his problem lists. The first of all, he has a 2 weeks accelerated hypertension and sign of volume overloaded, including primary congestion and general edema. The second is he has a dark urine and acute kidney injury comparable to weeks prior this visit, stage 2, and his urine analysis has hematuria, and his underlying disease is diffuse systemic sclerosis with current steroid usage. The differential diagnosis that I think is the first one is systemic scleroderma renal crisis because of evidence of high blood pressure and acute kidney injury. He has dark urine and anemia. This is a sign of intravascular hemolysis, might be Maha blood picture, and he was diagnosed diffuse systemic sclerosis within 4 years prior, and recently received steroids that are high risk to be scleroderma renal crisis. And the second differential diagnosis is RPGN, rapidly progressive glomerulonephritis. He has a high blood pressure, GFR declined, and hematuria within 2 weeks. That's can cause of RPGN. And the third then is ATN, acute tubular necrosis, because of his GFR was rapidly declined and can be mimicked about RPGN. And the last one that I will differential diagnosis is complement-mediated TMA because of systemic sclerosis, especially diffuse form, can overlap about TMA, can be present with intravascular hemolysis, such as Mahabat picture, acute kidney injury, and hematuria. That's all.
Anyone has any extra information, differential diagnosis that you all think that can possible happen in this patient?
Hello, I'm Dr. Wendy, the second year fellowship from Chulalongkorn University. According to the first year fellow problem list, I will add another problem list in this patient. In this patient has a problem about hyponatremia. The serum sodium has 126 due to clinical. This patient most likely hypervolemic hyponatremia due to clinical volume, have edema and saltwater retention. And in this patient have a maybe we have to consider about the cardiorenal syndrome in this patient due to have the volume status hypervolemic hyponatremia. And another problem list in this patient is myeloanemia and thrombocytopenia is compatible with the differential diagnosis of first year fellowship that about TMA or Mahabat picture or intravascular hemolysis. And in AKI in this patient maybe ATN due to rhabdomyolysis because have a blood in urine or intravascular hemolysis due to anemia and thrombocytopenia. But I think the most likely differential diagnosis in this patient is the first is a sclerodermal renal crisis, and the second is we have to consider about the RPGN in this patient due to he has a autoimmune disease like sclerodermal renal crisis. Maybe he have a overlap syndrome or mixed connective tissue disease with overlap with lupus, and we have to consider about the immune complex in this patient. And another one is ATN, any ATN due to drug NSAID or hemolysis or rhabdomyolysis in this patient.
Very good. I think we can almost end the lecture by now. Thank you. So we will proceed. I will get Khairil to continue with the subsequent investigations that we have done.
But I'm gonna correct Dr. Wani a little bit because sodium is 112, it's not 126. Dr. Wani, is it 112? So
sorry, 100.
Yeah, 112, 112. So any initial management before you approach?
First of all, I would like to see the diagnosis investigation. Can I have a blood smear picture and kidney biopsy would be performed in this patient for accurate diagnosis?
No. Well, I think the beginning, you need to stabilize sodium first because the sodium level is quite low. It's 112. So it's 112 is quite low and blood pressure is quite high. So you need to stabilize this thing before you go to kidney biopsy. In my opinion, you need to investigate the cause and you need to give an initial treatment first.
Okay, thank you. The initial treatment about hyponatremia is would we give the loop diuretics for the diuresis, the volume overload for correct the sodium, and then to stabilize blood pressure, I will to give the anti-hypertension.
Right. Thank you for all the input. Let's just proceed with the case discussion. All right. So these are all the other investigations that we actually proceed. The bold is the abnormal result noted that the CK was actually high, 2000 plus with a significantly raised in troponin. The LDH was also high. The urine FMA that showed hemoprotein with the 24 urine protein actually showed around 1 gram of proteinuria. The CRP as well on the higher side. We did send a few other parameters. The ANA was positive with a nuclear pattern. The complements were normal. The anti-SSA and anti-SCL70 was positive. We did send all the other RPGN workout, the MPO, PR3C ANCA and antigen was negative, but the P ANCA came back as positive. Infective screening at that point of time was negative. So this is the chest X-ray. As you can see that when she presented to us, it's very congested and with high white cell, high CRP, probably component of infection on top as well. So what we did, I mean, the initial impression during the emergency visit was a diffuse cutaneous systemic sclerosis in flare, covered for hospital acquired pneumonia because he was just discharged from a private hospital 2 weeks prior. The non-oliguric AKI could be sepsis, rhabdomyolysis with review of the high CK, could be cardiorenal because it's clinically overloaded with high troponin. And the other dimension would be, is it sclerodermic renal crisis or not? So what we did initially, started on antibiotic, IV tazocin to cover for hospital-acquired infection, offload him with IV furosemide. We withhold the immunosuppression because he treating for infection at the point of time. MMF was withhold. The cardiopin also withhold because noted all this subdural bleed and hematoma and everything. Started on captopril to control the BP and also to cover for scleroderma renal crisis. And at that point of time, the treating doctor actually started him on IV hydrocortisone 200 milligram stat and as well 100 milligram TBS. Okay, so I'll proceed with the trend. So now she was admitted to the ward. When first came in, we started him on hydrocort, started him on captopril to control the blood pressure. And you can see that the creatinine slowly keeping up. And at that point of time, we stopped the high dose of steroid and we just control him with lower dose steroid that he's on prior to this. The reason why will be explained later. Also, we optimize the medication, the captopril, to keep the BP normotensive, and the BP in the ward is around 130 to 140, sometimes go up to 150. Despite that, despite controlling the infection, despite controlling the blood pressure, noted that the creatinine keep on coming up in trend, and until one point that we decided, okay, we need to biopsy him, but because he was not so optimized, we inserted a femoral catheter, dialyzed him a couple of times, and only eventually we managed to proceed with the renal biopsy. Also looking at the CK trend is because initial impression could be because of rhabdomyolysis. If you can see that the CK level from 2000 slowly come down, however, the creatinine also slowly picking up. Again, another differential, we were talking about, KMAs and MAHA. As you can see here, initially when they came in, the platelet was 170. And as the day goes by, the platelet is actually just coming down until 50. And the LDH jumped up to 1000 plus, subsequently it came down. But after 1 week plus of admission, the platelet is actually started to normalize back, and this is where we actually did the biopsy. The hemoglobin is maintaining around 8 to 9. The white cell is still high, but it's just reducing a bit in trend. We did send a full blood picture during this point of time, but the full blood picture didn't actually show any picture of MAHA. It just showed that mildly reduced platelet with some normocomic normocytic anemia. There's no cystocyte seen in that initial full blood picture. I didn't show here, but we did repeat another full blood picture at the end of the therapy. Also, it was actually didn't show any MAHA. So at that point of time, we were thinking, is that rhabdomyolysis causing the worsening AKI? However, the CK level is actually just reducing in trend. Are we dealing with a sclerodermic renal crisis? Yes, we already started on ACE inhibitor. We did control the BP in the ward, but now the creatinine is still worsening. Is there something else is going on? Is it RPGN? Because the NA is positive. Yes, the complement was normal, but P ANCA also is positive with underlying scleroderma. Could be an autoimmune disease component as well. Is it sepsis? Because he came in with high white cell, high CRP, with that bad in lung, chest X-ray, but the septic parameter does improve after few days of admission. The culture was negative, and he actually completed 1 week of tazocin, and the culture didn't grow anything. So the other differential could be, is it possible cardiorenal? So we proceed with the biopsy. I think I'll pass to my Dr. Anissa, our renal histopathologist, to describe on the biopsy report.
Dr. Khalil, before go to the biopsy, so How about the hyponatremia? What's it?
Sorry, I
Etiology, the
didn't
cause?
mention. Yeah, about the hyponatremia. After we started him on diuresis, we offload him with IV furosemide. The sodium actually does improve, does normalize once we offload. So it's just because of the hypovolemia that point of time.
And because the case have systemic sclerosis and blood pressure is high, so it might be and also bleeding tendency. So it's going to be a relative contraindication for kidney biopsy. Do you do the kidney ultrasound before any decision on the biopsy?
Yes, we did the ultrasound, and the size is still okay with the good cortical media differentiation. So that's why we proceed with the renal biopsy.
Okay, so probably because we have time quite plenty. Any fellow from the other country, not Thailand, want to differential diagnosis before get the biopsy and read the biopsy? Anyone from Singapore, Indonesia, Philippines, or Malaysia? Not from Ipoh. Not from Ipoh. Anyone want to raise any comment or idea? Dr. Olaisa, Dr. Olaisa, are you here? Okay. Do you want to say something? What is your differential diagnosis?
Yeah, I think
And Dr. Olaisa is from Indonesia. You have to introduce yourself first.
Oh yeah. Good afternoon, everyone. I'm Oriza. I'm a second-year fellow from Universitas Indonesia in Indonesia in Jakarta. Yeah, so I think Dr. Harold is already stated very completely. So patient will come with fluid overload and then unresolving AKI. So yeah, the different diagnosis is rhabdomyolysis, and also the infection maybe because of the pneumonia and renal crisis. But I think also about how about the cardiac condition, because systemic sclerosis also tend to be pulmonary hypertension, and maybe this could make the edema worsen, and also could affect the cardiorenal syndrome that could reduce the renal function. Maybe this one should be addressed also beside the other differential diagnosis.
Hello, can I add a question too? So I'm Nusrat, I'm from Ethiopia. So I'm here for the peritoneal dialysis training in Chulalongkorn University. So I wanted to ask the presenters a question. So you considered scleroderma renal crisis for this particular patient while the urine is somewhat active. So rather than scleroderma renal crisis, why didn't you take RPGN as the first differential diagnosis, or more than the scleroderma renal crisis? Thank you.
Thank you. Anyone else? So what do you expect from kidney biopsy if we pursue to biopsy? So what do you expect to see? Anyone want to cast your expectation from biopsy before reading? Anyone else from Philippines? Anyone?
Hi, good afternoon. So if we're thinking about scleroderma renal crisis, usually because of the course of the disease, usually a renal biopsy would not be necessary, except if we are considering a typical form or presentation of SRC. Like in this case, wherein the acute kidney injury is not responding, even or despite starting the patient on ACE inhibitor, the thought about RPGN is now highly considered. So that's why if the patient's condition becomes suitable, then I think a renal biopsy would be warranted in this case because the AKI is not resolving. But yes. And other forms of vasculitis that may cause RPGN is now being considered. Thank you.
Yeah, wonderful. That's an important point. So I'm gonna hand to Dr. Kwalim. Kwalim.
We'll get Dr. Anusha to show the biopsy results, and perhaps we'll stimulate some discussion.
Yep, thank you, Alison.
Hi, good afternoon, everyone. Can you all see my slide?
Yep.
Okay.
Very
So I'm Anusha, and I'm the histopathologist from Hospital Ipoh, and I've been reading with special interest in renal pathology. So I was assigned for this case together with another colleague of mine. And for this case, actually, we received a good call, which had 22 glomeruli. And
apologies, Dr. Anisha, can you, interrupt you a few moments? So probably we're gonna give the fellow to try to read the pathology, and then you will review after they try to interpret. Is it okay?
Yes, sure. Yeah, that's okay.
Okay. How many slides? How many light microscopic slides?
That's quite a few because this case has electron microscopy also.
Okay, so maybe let them just only read LM.
Okay, yeah, sure.
Okay, so who's gonna be volunteer to read the slide? Probably Dexter, right? You is the last person to discussion. Okay, are you okay, Dexter?
Sorry?
No, I asked a fellow from Philippines.
Oh, I can try.
Okay.
So we have here on this slide around 20. Oh, around 8 to 10 glomeruli in this slide with I can see some focal sclerosis here with
Or maybe you need to have partner or colleague to help you.
sorry.
I saw you sit in the big room, have so many people there. Anyone want to help Dexter?
Doctor, can I help, please?
Yep. Of course.
Thank you. Good afternoon, Doctor and Professor. I am Anglita from Bandung, Indonesia. Please, Dr. Anusha, guide me. I would like to try to look and evaluate this. So on this slide, I can see 1, 2, 3, 4, 5, 6 full shape of glomeruli and one non full shape of glomeruli, and also 2 vessels. And then for the glomeruli itself, we can see that many deposit along the mesangial, and also maybe proliferation of the mesangial cells. And then the next, in the interstitial, we can see that some of the inflammation cells are there in between the glomeruli and also the vessels. And maybe there is a mild fibrosis. And then for the tubuli, some of the tubuli look still lined by the cuboidal epithelium, but some of the epithelium also looks erosive, and some of the tubuli, I think it looks starting to be atrophic. And then for the vessel, it looks like that the vessels, for me, some of the lumen looks starting to obliterated. Maybe the tunica media it's become sclerotic. I don't know because this is just from the HNE. Thank you. Please, Dr. Anush.
But no
guide me.
question,
Thank
right?
you.
Because we differentiate.
No. There is only a deposit in the Bowman space. Excuse me. There are many pale deposit in the Bowman space of 1, 2, 3, 4, 5 glomeruli, but also still left some open rooms. But yeah, I don't know what kind of deposit. Maybe this is just only HNE. Maybe on the histochemistry staining, we can have some more information. Thank you.
And how about pigmented ATN?
The ATN, yeah, there is some like a cast
No, pigmented
intratubuli.
because the patient have very high CPK and that
Oh,
you
yeah.
do you see any feature of pigmented related ATN?
Yes, indeed. There are some of dilated of the tubule. Also, I don't know, it's not that clear, but there is some materials deposited in the lumen of the tubuli, I think, if I'm not mistaken. So yeah, I think that's also maybe the etiology or for the dysfunctional of the electrolyte balance of this patient.
Now it's Dr. Anusha
Yeah.
gonna review your answer.
Okay. Thank you, Dr. Anglita. I think your approach was quite systematic. I think the GLOM as such, at this lower magnification, it looks a bit as if it's cellular. I agree with that. And because I have gone through this slide for so many days and so many times, and I will show you the higher magnification. But actually what we are seeing is that the glomerular, this is what we call as bloodless appearance of the glom, where the glomerular tuft, we hardly can see actually the capillary lumen. Again, this is low magnification. For a histopathologist, it's a bit easier to make that kind of judgment. And we can see that there's widening of the urinary space, and this indicating there is some kind of ischemic changes going on. And like you correctly said, there are some kind of granular material within the urinary space. And also that kind of similar material, we are also seeing it in the proximal and in other levels, even in the distal tubules. And apart from that, the tubules, like what you clearly described, they are actually mainly showing that kind of API kind of changes. There is interstitial edema. And the vessels is actually showing intimal thickening, which is almost moderate to severe with luminal narrowing. And this is actually the higher magnification. I hope probably now, the thing is, that's why we usually do special stain in histopathology, because stains like PAS and silver, they actually tell you where is the cellularity, if there is a cellularity. Is it in the endocapillary? Is it in the extracapillary region? So if you look here, this glom, which in low power looked as if it's cellular, it's actually giving you that kind of very collapsed and bloodless-like appearance. And of course, there is some with congestion. And this PAS stain, we can see that some of the capillary lumens are open, and we are also starting to see this kind of double contouring. And apart from the double contouring, we see that the endothelial cells are rather swollen with some intracapillary infiltrate, giving that kind of glomerulitis-like appearance. And the podocyte seems to be a bit jumpy, but we don't see any vacuolation or foamy appearance. And whenever we see this kind of thickened GBM with double contouring, the next thing that comes to our mind is there some kind of deposits? So MP and silver helps us with that, and we did not see any subendothelial deposit or subepithelial deposits, so membrane vacuolation to suggest any kind of membranous component going on. And there were no extracapillary proliferation to suggest crescent formation. The endocapillary, there's also no endocapillary hypercellularity as such. But again, this granular material that we saw on silver, they are aerophilic. And maybe somebody wants to give a try on this slide. If not, I will just proceed.
No.
Okay, so
Anyone want
here
to
is
try?
where
Anyone want to try first?
I think in the middle picture, they have a fibrine deposit at the top of glomerulus is most likely TMA, right?
yes, correct. I mean, how would you describe actually this So what we are seeing is actually this arteriole, which is feeding into the glomerular hilum, having fragmented RBCs in the vessel wall. And this downstream glomeruli appearing rather ischemic, and in this part we can even say that it's having that kind of bloodless appearance, but no mesangiolisis or fibrin thrombi we see within the glomeruli. And in other areas, actually, the arterioles, we see this, what we call as intimal mucoid edema, with this kind of bluish appearance. And move my Can you see my screen now?
Yep, of course.
Okay. So apart, there was not the only glomeruli. There were actually few others showing that kind of similar feature, where we have the arterioles having this kind of fragmented RBC within the vessel wall, and we also saw this kind of eosinophilic homogeneous material within the lumen and within the vascular wall as such, accompanied by this kind of endothelial swelling. And we proceeded with, I mean, whenever we see this kind of eosinophilic material for a histopathologist, we start wondering if this is plasma inundation, is this immune deposits, or are they fibrin material? So when I saw this kind of histology, of course, on top of my mind is I want to exclude fibrin. And for us, MSB is one of the useful stain, and fibrin usually highlights as red. And so does anybody want to give a try on this slide? In terms of description, I think everybody knows the diagnosis already at this time.
Anyone else want to try to describe the pathologic finding? Because the diagnosis, Dr. Anusha already revealed.
Yeah.
Anyone want to? No.
Okay. So apart from that, what we see is this larger interlobular artery showing this marked fibrointimal thickening. And on silver, we can actually see the laminated layering of the fibrointima. The IFTA as such was actually not much, about 15 to 20%. What what was there separating the tubules were actually a lot of interstitial edema. For this case, the RF fresh tissue did not have
Dr.
any
Anusha,
globes.
Dr.
Yeah.
Anusha, can you point out the fragmented less cell, because I think it's key important finding for the fellow. Can you point out a little bit?
Okay, so you can see here this arteriole. This eosinophilic material within the lumen is actually the fibrin. And you start seeing these reddish RBCs, which are, they don't have that rounded appearance like a normal RBC. They are rather fragmented and they're seen within the vessel wall. And apart from that, so this is another very nice glom where you can actually see these red cells. These are the fragmented RBCs within the vessel wall, which is one of the characteristic features for a vascular TMA, apart from the internal mucoid edema that we see here.
Thank you so much. The less cell outside the lumen. So add what I summarize that.
Okay. So coming back to the IF, so we proceeded to do IF on paraffin. And actually, apart from the non-specific staining for C1q, which was very weak, and there was fibrinogen positivity on the vessel, all other immunoglobulins and light chain and complement were actually negative. So in summary, what we have is the glomerulus on low power looking a bit cellular, but actually when you go higher power, it's actually these gloms giving that bloodless appearance with ischemic changes. There is duplication of the GBM, but however, we don't see any deposits as such, that the subendo or subepi mesangial. And the podocytes, they look a bit jumpy, but we don't see any foamy or lacy vacuolated cytoplasm by light microscopy. The arteries as such, the interlobular artery display moderate to severe fibrointima thickening, and there's also mucoedema and mixed change of the arterioles. And all those TMA changes that I mentioned earlier with this kind of fragmented RBC seen on the vessel wall and MSB positive fibrin material present within the lumen and also in the vascular wall. The tubules as such showing ATI changes, and there were this kind of granular casts within the lumen mixed with cell debris, and there's interstitial edema with mild to moderate interstitial lymphocytic infiltrate. And like Prof earlier already asked regarding casts. So given that clinical scenario, one of the thing that we have to look for is myoglobin cast. And in this case, we did not find that kind of ropey, pigmented cast within the tubules. And these were more very finely granular and similar in quality of what we see within the Bowman's capsule. Which at that point, we thought of granular cast material, probably associated to the ATI and unlikely to be a myoglobin cast. So I think everybody at this juncture already has a morphological diagnosis in mind. And so the diagnostic summary at that point was subacute vascular thrombotic microangiopathy accompanied by diffuse glomerular ischemia. And there was no evidence of immune complex mediated glomerular nephritis. There was ATI with acute or chronic tubular interstitial inflammation with mild IFTA, no myoglobin cast, and moderate to severe arterial intima thickening. And given the clinical history, the TMA could be due to various etiology, and the morphology is rather similar. And at that point, we were thinking of scleroderma, systemic sclerosis related. And so just in terms of pathology, scleroderma is usually, they come with more vessel involvement over glomerular alteration. And they can also have prominent juxtaglomerular apparatus hyperplasia, but in this case we did not see. But what I showed earlier in the silver stain is that marked arterial intimal thickening, which is more commonly seen in diffuse cutaneous scleroderma rather than the limited type. And most of the ancillary testing are not very helpful because RF can actually be negative, or even if there is, there will be non-specific entrapment for IgM and complements. And of course, renal biopsy will be also worthwhile in this kind of cases where we want to exclude any other superimposed or coexisting pathology. And we did not see any crescentic pattern or any kind of immune complex mediated GN picture in this case. Can I proceed to the electron microscopy?
Yep.
Or is there any questions?
Please.
Okay. So in this case, I'm not too sure how familiar everybody is, but just to make the discussion easy to understand, I will just take through you guys how a normal GPM looks like under electron microscopy. So we have this is the podocyte with the podocyte food processes and the filtration slit diaphragm. And we have the GBM with the lamina densa. And on the opposite sides, we have the rara interna and externa. And here on the inner luminal aspect is where we see the endothelial fenestrate. So coming to our case, actually we had two glomeruli. And even in this, we can already see that the glomeruli is very diseased. And if you want, let me just orientate you. So this is the GBM. And we can see that there is this is the lamina densa, and there is marked subendothelial widening, followed by this is the luminal space, and we don't see any more of the endothelial fenestrae here. And this subendothelial lucent area, we see this kind of floccular material, some mesangial interpositioning, and also some electron dense-like material. And the podocyte is rather sickly. We see a lot of microvillus transformation, the podocyte being enlarged and vacuolated, but no particularly abnormal structures that we see within the podocyte or urinary space in this glom. Like I said, there was two gloms. And again, similarly depicting that kind of subendothelial lucency with floccular material. All these are features that we usually see in a case of TMA. And the endothelial cytoplasm is so swollen up and filling up the entire lumen, like what we saw in the H&E stain. And we don't see the endothelial fenestrae anymore. Some of the podocyte still has the filtration diaphragm, but in most areas it's already effaced, as we can see here. And we also start seeing all this new membrane formation, somewhat from subacute to chronic kind of changes. Apart from that, we saw this one tubular reticular inclusion in the endothelium. So usually tubular reticular inclusion is something that we commonly see in SLE and in viral infection like HIV because of the high interferon state. But there have been reported cases of TRIs seen even in scleroderma. And the mesangium as such also shows this kind of electrolucent areas, but no EDDs as such, again to show the very sick podocytes with the microvillus transformation. And in this particular grom, the urinary space, we did not see any kind of suspicious deposits. Podocytes are very effaced, and this glomerular tuft is actually collapsed and ischemic. So what are these argyrophilic granular material that we see within the urinary space and also going into the tubules? So this is the other glom that we saw. And so to orientate again, so this is the Bowman's capsule. And this whole thing here is the urinary space. I hope everybody can see my arrow. And
and we can see very well.
Okay, and so this is the GBM and the podocytes. So this particular image shows that the urinary space is filled with this kind of laminated bands and clear membrane-bound structures. And some of them even appear a bit laminated in this way, giving you that impression of a zebra body or a myelin bodies, we call it. But admixed with it are these more dense appearing membrane bound structures and more loosened appearing membrane bound structures. And again, this is the Bowman's capsule. So this must be the parietal epithelial cells. So we see an occasional one within the parietal epithelial cells. But as I was taking you through the other images, we didn't really see this kind of material in the endothelial cells, or it was not identifiable in the tubular epithelial cells. So they are mainly seen within the urinary space, with very occasional ones seen within the parietal and visceral epithelial cells. So the EM findings, to summarize it, is that I think in terms of the TMA changes, they are there. And they are quite classical, electron-loosened areas with flocculent material, duplication of the GBM, and effacement of the food process, indicating that this is maybe going into a subacute chronic kind of TMA changes. We did see an isolated TRI, which just indicates that it's a high interference stage and not unusual to be seen in scleroderma. So now coming to these laminated inclusion bodies, like zebra bodies-like material in the urinary space and not so much in the podocyte and the parietal epithelial cells. So, I mean, among the audience, is there any histopathologists here with interest in renal?
Probably the zebra body related to medication instead of Fabry syndrome. I think because the patient got chloroquine.
Yes, correct. I think that was that's what we are thinking of at this point. And it's just that a lot of these zebra-like bodies that we are seeing are mainly in the urinary space. We don't see it much in the podocyte or in the parietal epithelial cells. And they are not very well formed, like this kind of very regularly laminated as what we see in Fabry's disease. And even by light microscopy, we did not see this kind of lacy podocytes. And the clinical presentation is also not typical. They come with more systemic manifestation, and the age also doesn't fit into it. So this is the closest article that I could find where there's a case report. This is quite a recent article published last year in a patient with systemic sclerosis, but she has another ongoing thing going on, which is the monoclonal gammopathy. And in this patient, actually, they demonstrated this renal phospholipidosis. Whereby these phospholipids are actually stored within the lysozyme, within the intracellular component of the podocytes. So I think given the best bet based on the clinical history, it kind of fits into the drug history given for this patient. But I think it would be also noteworthy to really do a thorough clinical evaluation for this patient. Yeah, I think that's all for my presentation. Any questions?
Any question from the floor? Dr. Kyril, do you want to ask anything before we take the floor?
Dr. Tarir, if you don't mind me asking, do you commonly see this kind of inclusion zebra bodies in cases of scleroderma?
I think should be unusual for scleroderma crisis to have zebra body, but I think because the patient have very active, treated with the chloroquine. Maybe if you want to make sure, you have to measure enzyme level to totally exclude Freiberg, but usually Freiberg we can diagnose this by clinical manifestation like cardiovascular disease, angiokeratosis of the skin or something like that.
Yeah.
Is it okay if we just continue with the for the subsequent slides? I have a few more slides I would like to discuss on renal crisis.
So another Kylo, you're gonna share slide, right?
I'll share my slide.
While waiting is a very interesting, comprehensive, and medical preparation for the Anusha. Thank you so much.
You're welcome.
So we have a tight schedule. Probably only 2 minutes. It's okay for you?
Oh, okay. Then probably I just skip a few of the slides. Just basically just talking about TMA. I think most of us already know what is TMA, how does a cystocyte look like. Those causes of TMA, you have primary TMAs and secondary TMA. For our cases, this is secondary due to scleroderma renal crisis. And approach of TMA, probably because of due to lack of time, I'm just going to skip this. But do know that, of course, you need to send your ADAM-TS13 before you start any of the plasma exchange to get the diagnosis. Talking about kidney involvement in systemic sclerosis, we know that kidney disease in systemic sclerosis is actually quite common. 60-80% of them would have some degree of some renal impairment, but amount of them that actually go to scleroderma renal crisis around 10%, and probably less than half of them will actually had secondary TMAs. And this is how the UK Systemic Sclerosis group actually has a diagnostic criteria on diagnosing scleroderma renal crisis, evidence of high BP with some kidney failure and evidence of MAHA. How the renal crisis actually develop is still not really that well understood, but we do speculate that that is because of the underlying background of atrial fibrosis and chronic vasculopathy with sudden endothelial cell activation and smooth muscle cell proliferation due to the systemic sclerosis. Thus leads to all this thrombosis, the glomerular ischemia, and fibrosis. And the most thing Dr. Anusha also mentioned the hyperplasia of the juxtaglomerular apparatus, which cause in a sustained activity of your renal adjunctive system. And this is where our ACE inhibitor actually do work because of this decrease in blood flow to the renal, causing hyperplasia of your juxtaglomerular apparatus and increased production of your renin. So that is why we give our ACE inhibitor, hopefully can halt the progression of the renal cell crisis. Endothelin-1 receptor also do play in role because most of the patients who had this scleroderma renal crisis, when we did the biopsy, there is evidence of endothelin-1 receptor, and their levels of endothelin-1 in the serum also is actually higher compared to the controls. So we know that endothelin-1 also plays a role in vasoconstriction and endothelial injury, also the interstitial fibrosis and inflammation. What are the risk factors for those scleroderma developed renal crisis? Those who are having a very active lesion, diffuse, rapidly progressive lesion, and the duration of less than 4 years, within a year, those are those patients who have high risk of developing renal crisis. Anti-RNA polymerase II antibody positivity also put them at risk. Another thing that I would like to mention is using of steroid, because in our case, when the patient presented initially because having a scleroderma renal crisis, we thought it was inflamed. We pushed up the steroid to 100 milligram TDS. What happened is that this kind of group of patients who has an increment of steroid dose does have high risk of developing scleroderma renal crisis. So do bear in mind, giving high dose steroid in this group of patients would be something that is not advisable and is based on case-to-case basis. What are the outcomes? Before the initiation of ACE, before the era of ACE inhibitor, the 1 year survival is actually very poor. 15% of them do survive within 1 year. But with ACE inhibitor, of course, the survival is improved. And this paper is a very, very old paper back in 1990s. We have another paper back in 2000 looking at the outcome, long-term outcome of those with renal crisis. 61% do have good outcome, 61% of them, and around 40% do have a bad outcome where they died or they have a permanent dialysis. Those who actually has a good outcome, those who actually went for temporary dialysis, the duration for them to stop dialysis actually ranging from 2 months to 18 months. So for our patient for those patients who develop dialysis, who require dialysis support, don't lose hope on them too early. Probably we can still wait and see if there's any recovery up until 2 years period of time. And the survival, if they doesn't require dialysis, the survival is actually quite comparable in this group of patients when they look at those who doesn't have renal crisis and those who actually recovered. They have quite a good long-term survival outcome. This is just a schematical diagram showing how to treat. I'm just not going to bore you with all the details. Just that the first line of treatment is ACE inhibitor. ACE inhibitor, if cannot, you give ARBs, other antihypertensive like your calcium channel, your direct renal inhibitors, or alpha blocker can be used as well. Of course, beta blocker we should avoid them because it can cause some sort of like vascular spasm and can worsen the renal Raynaud's phenomenon or renal ischemia. Other non-antihypertensive treatment that we can consider are those non-selective endothelin 1 receptor antagonists, like your bosentan, your iloprost, because it's a vasodilator, but of course it's not proven in renal crisis. Our complement inhibitor like eculizumab, there are few case reports showed that it does help, especially those who are refractory to your ACE inhibitor, who had a persistent renal failure, and those who had TMAs, but there's no clinical trial with this treatment. It's mostly a case report. How about PLEX? Because the patient has TMA, do we PLEX this group of patients? The rationale of using PLEX is because we try to remove whatever autoantibody, those cytokines, the vasoconstricting factors that related to this activation of RAS in the RAS system. Removing that, would that actually help in preventing worsening of your MAHA or your TMAs? There are no trial, but of course there are few observational studies looking at 606 patients of scleroderma. 3% of them developed renal crisis. Among them, half of them, they actually did PLEX. They look at the outcome or their survival outcome for those did PLEX. Not many, only 10 of them, but they had a better survival rate within 1 year and better survival rate in 5 years compared to those who are not giving PLEX. Again, this is just a very small group of patients. It's just a retrospective study, and still more data required to actually see if PLEX do help in this patient who had TMA and renal crisis. So just move on to our patient, Mr. CS. So we treat the scleroderma crisis with captopril. We optimize the dose, keep him normotensive. We didn't give PLEX at that point of time is because the platelet and HB was normalizing and the LDH was actually back to normal. We only continue with the hemodialysis support and observe for any renal recovery. Our rheumatologist team as well are treating the systemic sclerosis because of a very aggressive disease. They decided to give ivosaclofosfamide. At this point of time, he just completed the 3rd cycle and they are planning to continue with the subsequent cycle. How about the creatinine? So far, as of last week, the creatinine pre-dialysis is around 40. You can say that there's some improvement and probably not some improvement. Really not really sure how to interpret this. Probably we'll give some time, hoping that the kidney recover. His urine output is still okay. So just hoping for the best that his kidney can recover from this insult. I think with that, I'll end my talk. Thank you so much for everyone listening. Any other questions?
Thank you so much. Probably we don't have time for questions. So before wrap up, last but not least, please turn on your camera so we can take a good photo together. So during waiting for taking photo, so thank you so much for Dr. Khairil, Dr. Anusha, and fellow Dr. Tom for delivering such a compelling and thoughtful, provocative case. The recording of today's session will be uploaded in the YouTube. You can save the link in the chat box. So please feel free to share it with your colleague and network. So the next meeting is gonna be 26th of August 2028 at the same time. So I'd like to pass the microphone to Dr. Lily Mushaha, our Deputy Chair of the OSEA, for saying something before wrap up.
Yeah, thank you very much, Gov. It's only less than 6 weeks of we are heading towards our Congress of Asia Pacific Chapter of ISPD 2025 and our annual Congress of Malaysia Society of Nephrology, which will happen on the 3rd to 7th September. So please come and join us. I'm not sure whether you can see my slide now, but we are offering society benefit where a minimum number of 5, if registered, they can have a discounted Congress fee rate. And this is hopefully you can submit the names of the 5 members in the society to obtain this benefit by Sunday, 24th August. And I hope to see you all in Kuala Lumpur soon. Thank you very much.
So please open camera, everyone. Take a last photo. Oh, Sunita, hi. Oh, a lot of people, a lot of fellow there. So wonderful. Alex, thank you for your coordination. Sunita as well. Very wonderful. You're doing very good job, Kyle. Very good job. Very engaging.
Yes, I think it's
So,
yeah, too. Yeah.
So until next time, 26. So stay safe, stay curious, and also stay hydrated. And see you in Malaysia, KL, Malaysia for SPD Asia Pacific chapter.